TopMedTalk.
Welcome to TopMedTalk, the broadcasting arm of EBPOM, evidence-based perioperative medicine. Stand by for a healthy conversation. But first, the 2026 International Practicum on Cardiopulmonary Exercise Testing will be held from September the 16th to the 18th of this year. It is organised by iPoets, the International Perioperative Testing and Training Society. Come and join us at this premier educational event designed for clinicians, scientists and healthcare professionals interested in sport, exercise and perioperative medicine. Check out ebpom.org for the best prices and information now. That's ebpom.org. And remember, this is an International Perioperative Testing and Training Society accredited event. So when you attend, you can get your iPoets accreditation showing that you are a practitioner who has reached a high standardized level of competence in performing and interpreting cardiopulmonary exercise testing for patients preparing for major surgery. Check out ebpom.org now.
Hello, welcome to TopMedTalk. I'm Andy Cumpstey and I'm here with my co-host Kate Leslie at the Euroanaesthesia meeting in Rotterdam. That's the annual meeting of the European Society of Anesthesiology and Intensive Care. And it's great to be here, isn't it, Kate?
It's fantastic. I've never been to Rotterdam before. In fact, I haven't been to the Netherlands since I was a medical student. So it's great to be back.
It's really nice to be. I've not been to Rotterdam before either, but I have to say, it's embarrassingly how well everybody here speaks English. And I feel terrible that I can't speak any Dutch. We're trying to learn, aren't we? But
Dank u wel.
Dank u wel. That's as far as we've got. But we'll hear some more from that, I think, from our guests in a second. We should get on and introduce them. We've got some fan faves back to chat about their recent work.
Hello, good to be here again. My name is Bernd Saugel. I'm a professor of anesthesiology and the executive vice chair of the Department of Anesthesiology at the University Medical Center in Hamburg in Germany. Very much be looking forward to this podcast, and I'm happy to be back.
Brilliant, thank you. Denise?
I'm Denise Veelo. I'm a professor in anesthesiology, working in Amsterdam UNC. So I combine research with clinical work. Happy about that.
Excellent. I'm going to dive straight in because I'm really excited about this conversation because you've both published some, I think, really interesting work actually in the same day, I believe, in JAMA last year. Yeah. Both blood pressure related trials. So why don't you start by summarising those trials quickly for our listeners who may not have heard about them before, and then we can discuss what we think the importance of those trials is for all of us going forwards.
So we did a pre-treat trial, which was a 2-center randomized controlled trial, and we compared care as usual to a more intensive blood pressure management strategy. It was a big trial. At that time, there was no evidence yet, and there were a few trials done. Of course, now that's a bit different, but at that time, we had little evidence. And the aim of our study was to see whether more aggressive treatment would improve patient outcome. And our primary outcome was the WADA score, which is a patient-centered score, a 12-item score that covers 6 domains like self-care, mobility. So it's a different type of outcome.
So it's a functional recovery.
Yeah, functional. Outcome. It means is you measure actually disability. Yeah. Of course, we also had secondary outcomes like the usual ACI, mortality, etc. So we included 3,500 patients, and we actually stopped the trial for futility, because we had planned interim analysis done. And when we found out that we were not going to improve outcome, we had to stop the trial. So, but it's still, I think, a lot of patients. We're really happy with the results. And the design was a little bit special. I don't know if you want to talk about it now.
Yeah, so we can talk about the improved trial in a second, but I think both trials had similarities. But I think one of the key differences with your trial was how you selected the patient.
So we thought of it a little bit different. We wanted to do like an individual strategy, but we did a little bit different than Bernd or other trials before. So what we did is we first consulted a very large retrospective database and found out which patients had a lower, medium or higher risk of hypertension. And then we stratified those patients included in the trial for lower, medium or higher risk strata, and we adapted the blood pressure threshold based on the risk of hypertension. So the idea behind that is that we have a high risk of hypertension, you go fast and you go deep with hypertension. So to stay above the critical or the harmful a blood sugar threshold of 65. Below that is hypertension, that's harmful. We want to stay away from that threshold. And we thought it is more difficult to manage those patients that have a higher risk and go deeper and faster. And so we increased the margin towards the threshold of 65. But then you had the intermediate and the low risk, so we thought we can all do the same threshold, but also you have, of course, the harmful effect of vasopressors. You don't want to overtreat patients, so for those that have a lower risk of hypertension, we decrease the margin a bit towards the harmful thresholds.
So if I summarise that then, correct me if this is wrong, but so the lowest target for any patient in your trial was 65? That was the comparative group?
No, it's the 70.
But for the comparative group was 65? Sorry,
Yeah,
the lowest for all patients, the lowest target in the trial was 65?
Yeah, that was the comparative group.
And then in the intervention group, they got slightly higher than that, either 70, 80 or 90?
Agree, yeah.
Yeah. So I guess that's a nice point to segue over to you, Bernd, because you had a similar sort of structure with the lowest target of 65 in the improved trial, but then you took a different approach for the intervention group. Is that correct?
Yeah, indeed. We performed the IMPROVE multi-trial in 15 German university medical centers. It was funded by the German Research Foundation, and we included around about 1,300 patients and randomized those patients to routine hemodynamic management with a lower blood pressure intervention threshold of a mean arterial pressure of 65. In the intervention group, we individualized the blood pressure targets based on the preoperative mean nighttime mean arterial pressure. So our hypothesis was that in high-risk major abdominal surgery patients, keeping intraoperative mean arterial pressure at least at the preoperative nighttime mean arterial pressure compared to routine care with the lower intervention threshold of 65 improves outcomes in terms of a composite primary outcome of major complications and death. What we did to assess preoperative nighttime blood pressure is we performed automated blood pressure monitoring for one night at 30-minute intervals, and according to cardiology guidelines, we then calculated the mean nighttime mean arterial pressure considering all the values between midnight and 6 in the morning. So this were around about 12 values, we measured every 30 minutes. And from that we calculated the preoperative mean nighttime blood pressure that was then the target, but target is probably not the right word, it's always the lower intervention threshold, the threshold when clinicians started to intervene and try to maintain blood pressure. Primary outcome was a composite of acute kidney injury, acute myocardial injury, non-fatal cardiac arrest, or death within the first 7 days after surgery, and there was no clinically important or statistically significant difference between the groups. In both groups, the incidence of this primary outcome was around about 30%.
Which is really interesting. So there's two trials here which are both sort of, I guess, broadly set out with the same hypothesis that we think 65 is the minimum safe target. And then we've both come up with different interventions, but an intervention of individualizing a higher than 65 blood pressure target. And we can talk about that in a second. But one intervention was, as you say, a nighttime mean. Another one was a risk threshold, but an individualized above 65, which intuitively probably makes sense to many of us listening. But then both of you showed no difference in your different outcomes. So is the take-home message from that we shouldn't be targeting more than 65, or is it more complex than that?
On the other hand, the message can be quite simple, I think, on one hand. So I think when we talk about this threshold of 60 to 70, which is the consensus, threshold that we all think that it's good, I think it's safe. And you don't need to really go above that, at least not start vasopressors to really get higher pressures. Whether it's as simple as that, I think based on individuality, it might be different for some patients. But for the whole group, and this is what you measure, of course, in your trial, I think it's a straightforward answer that we don't need to increase blood pressure beyond that. Of course, physiology is a little bit more complex than that, I think. But I think this is the easy message. And yeah.
My take would be that those trials show consistently that we should not deliberately aim to achieve blood pressures substantially higher than 65. What we need to say, of course, is that there are some specific clinical circumstances where you still might want to go for a higher blood pressure. For example, if you have elevated intracranial pressure, elevated intra-abdominal pressure if you have surgery in a special position like sitting position, or if you have a patient with severe carotid stenosis, for example. So I think it's a safe statement that for the general population, although those populations differed in the trials, so you looked more at moderate risk patients, we had high risk abdominal surgery patients, but for those whole populations, you shouldn't generally and routinely go for a higher blood pressure.
Agree. Yeah. So the population that's a little bit more complicated because you look at patient characteristics as high patient, and we had this risk profile which contained both the type of operation and other factors. The most high risk patients were in the intermediate and in the high risk group. So that's the complex thing about it. So
both trials nicely match because they cover a really, really broad spectrum of patients. If you look at distribution of ASA classes and duration of surgery, type of surgery, I think those two trials very, very nicely add to each other.
So all trials have got limitations, and that's sort of, despite the fact that both trials were superbly executed and come from prestigious research groups. So one of the reasons that the intervention might not have worked is that it wasn't applied accurately or for long enough or with enough faith from the anaesthetists. And so it might be that you didn't prove that something that was effective might actually work. Another hypothesis is that the tools that you both assessed are not the ones that are going to make the difference. Or the horror of horrors, it might be that blood pressure doesn't actually matter, that all the observational work was just a fantasy, and that what the real problem is something else. So I guess let's start with the limitations. Was the intervention faithfully administered to the patients in each of your trials, Denise?
Yeah, so we looked, at least we tried to say something about it by looking at the contrast between groups, which was one of the criteria where we would stop or continue the trial with the intermediate analysis that we did. So we found contrast, so this was really important for us. But of course, this contrast is also, limited by itself, how you look at it. But we tried to look at it in various ways, and we found contrast between groups. But when you look at the mean blood pressures, both groups, they are very close. But you see this in every trial. The mean blood pressure only difference like 7 millimeters of quick mercury.
The conclusion is that anaesthetists in your hospitals can implement the intervention.
Yeah.
It's not an impossible request that you're making.
Oh, but if I can add on that, we are also doing a sub-analysis now to see how we can look at compliance to the intervention. So this is what we're still working on, to see what are the difficulties there. Because there are, of course, difficulties. And especially for us, for the higher target map, like 90, there was a little bit of resistance. So, yeah.
Yeah, what about you, Bernd? Was the intervention faithfully executed?
Yeah, protocol adherence was very good.
It's always good in Germany.
And I'm very confident that the separation between the groups in intraoperative blood pressure was good enough. So we looked not only at median values every 30 minutes during surgery, but we calculated the area under blood pressure thresholds, which kind of summarizes both the severity and duration. Blood pressure is below a given threshold. And looking at this separation in blood pressure exposure was quite substantial between the groups.
Yeah.
However, I need to say that we do not really know how clinicians reach the target. So I would be more worried about the fact that we didn't use a specific treatment protocol. And what we see is that there was hardly any difference in the type and total amount of fluids patients were given, but there was a difference in the amount of vasopressors and in the proportion of patients who received vasopressors. So my guess, if you ask for an explanation why the intervention may not have worked, could be that the interventions clinicians chose to reach the target was most of the time simply vasopressor, because it is the easiest and quickest intervention to achieve your target. And perhaps, or I'm pretty convinced that this is not the right way to go. We should always treat the underlying cause of hypotension and not just correct the number on the screen.
So another question then is, did you demonstrate a difference in the administration of sevoflurane or propofol between the two groups? Because anesthesia is the main cause of hypotension intraoperatively, and has been shown that if you restrict the amount of propofol or sevoflurane you give, then the mean arterial pressure will be higher.
Yeah, so we did, I'm not sure if it got published, but if it's in the results, but we did look at it. There was no difference. And we actually found the same thing as Bernd, a lot of use of vasopressors and not much difference between fluids. So that's why we want to look at this in sub-analysis, because I think it's actually a very interesting question. Yeah.
And I think this reflects like a general trend. There are good observational retrospective data showing that if you look at the last decade, probably because of all the observational studies always emphasizing that hypotension is bad, that clinicians tend to give more vasopressors, not only in the United States, but also in other countries, including many countries in Europe. And this may have become kind of a reflex of the anesthesiologist as soon as blood pressure drops to give a vasopressor. In many institutions, most of the patients now have continuous pressors from the beginning of anesthesia, and this is probably something where the pendulum will swing back a little bit in the next years.
You published some lovely work with Dr. Thompson about the fact that both hypotension and vasopressor administration are bad. And I guess, you'd have to work out that it's a complex sort of relationship among all those things, isn't it?
Yeah, both are independently associated with acute kidney injury, and it's probably our challenge to kind of balance those negative aspects. One is hypotension, the other one is excessive amounts of vasopressors. The third one, by the way, is excessive amounts of fluids. So we kind of need to find a balance, minimizing all those harmful interventions or conditions, and try to figure out the best way to handle those.
So I think, summarising my question, Andy, it seems like the trials were good assessments of the interventions that they chose to look at, and the patients were at high enough risk. There was loads of hypotension and lots of bad outcomes. And even in the context of a high-quality trial, the interventions didn't work, which is really sad in a way. But if it did work, then it would all be over and we would need to do more research, Andy.
Absolutely. But just to follow on from what Bernd just said, I think, many of the listeners will know I work in an intensive care unit in Southampton. We have a separate, what we call a high dependency unit, but it's essentially an EPOC, a sort of a surgical-only enhanced recovery sort of unit. And the number of times I admit a patient to one of our units with a surgeon telling me to keep the map above, pick a high target, 70 or 80, number to be agreed on the day, but don't use pressors, don't use fluids,
Yes.
Just use a magic wand. And so that's impossible, right? And, there'll be a lot of people listening to this saying, okay, so these trials are telling us, as we just said, hypertension is bad, but pressor use is bad and excessive fluid use is bad. So what is the next stage for this? I mean, what should clinicians take away from both your excellent trials into their day-to-day practice? How should they be looking at the patient in front of them and looking at the blood pressure? What should they be doing?
It is still important to emphasize that none of those trials randomized patients to hypotension. So I'm pretty sure that we still should stay with the message that you should avoid profound and prolonged hypotension. Mm-hmm. And I would define it as a mean arterial pressure of less than 60 to 65 for a couple of minutes, let's say 5 or 10 minutes. And then we need to understand, and I still believe in this, that there is inter-individual variability, not only between individual patients, but also between the organs within a patient, and we need to always have the full picture. So having a mean arterial pressure of 65 with a very, very high dose of vasopressor is probably more harmful than having a moderately low blood pressure with no vasopressors. And this is also the research agenda for the next years, to figure out what an optimal constellation between those therapeutic intervention and the blood pressure could be. And of course, there are additional hemodynamic variables like cardiac output, stroke volume, heart rate that we need to keep in mind too, because now everybody is very, very much focused on blood pressure. And I think we need to make sure that everyone understands that cardiovascular dynamics are a complex area with a lot of different hemodynamic variables we should take care of.
We need to dive deeper, don't we, to tissue perfusion and right into the cell to mitochondrial function and all of those things.
Yeah, but also figuring out what to measure. Because what are good outcomes? I think there's still some work to do at that part as well. And I totally agree with all the other things that Bernd just said.
Yeah.
So what do you think we should be measuring then, Denise? What are the good outcomes? What should we be looking for?
I think that is quite a complicated question. So maybe more direct organ damage. But then you are in the biomarker section, and which is also very expensive. So
and delayed. I mean,
delayed
so getting a biomarker in 48 hours time from the lab result is not helpful to the.
Yeah. So I don't think I'm that we are out. The jury's not out yet on that, I think. I think there's some work to do in this part. And we have a fantastic groups of people that are working on this question. So I'm sure something will come.
So really exciting work. Thank you both. Can we get a sneak preview about what you're working on next? What's the next sort of step in this journey, or what's the next stage? What should we be looking out for in the future?
Yeah, we are now working on a even larger trial, 3,500 patients, only old patients with a very, very high risk of developing delirium. And all of them will have chronic arterial hypertension. And we will randomize those patients to 65 in the routine care group, where there's a higher blood pressure target still, and want to know whether we can reduce the incidence of delirium, because there were now 2 meta-analyses, including a couple of trials, including the 2 that we discussed today. And there is one outcome that kind of shines out a little bit, and this is delirium. So there might be a signal that you could reduce your delirium in high-risk patients with higher blood pressure targets. We want to figure out if that's going to work, but this will take a couple of years.
What's the acronym for the trial, Bernd?
It is Aspire 85.
Oh, I'm inspired by that title. And what about you, Denise?
Yeah, so we're still thinking about what we want to do, but our group is also working on autoregulation, brain autoregulation,
yes.
and more physiology things as well on organ level. So I think, of course, are both groups not working on just one trial. We're doing a lot of small steps. Post-induction hypertension we're working on. So there's a lot of things that we can do to bring us closer. But I think that we also need to take a lot of small steps to better dive into the physiology part. But it's actually quite difficult to design in a large trial. So small works, but yeah, I think also very cool.
Oh, keep up the good work. It's fantastic.
Yeah.
And make sure you come back and tell us the results in a couple of years' time. It's been great having you both on the podcast. Thank you for joining us.
Thank you for having us.
Thank you for listening. As always, you can find this episode and all our other episodes through our website, TopMedTalk.com, or through all the main podcasters. We're on all the common social media channels as well: YouTube, Facebook, Instagram, Blue Sky. We're on them all. Whichever one you find us on, please hit like, please hit subscribe. It really does help us at this end. And of course, a huge thank you to Zayek for hosting us here at Euroanaesthesia, and to our sponsors this year, which is BD Advanced Patient Monitoring and GE Healthcare. See you next time.
Cheers.
TopMedTalk. And remember, the 2026 International Practicum on Cardiopulmonary Exercise Testing will be held from September the 16th to the 18th of this year. Come and join us at this premier educational event designed for clinicians, scientists and healthcare professionals interested in sport, exercise and perioperative medicine. Check out ebpom.org for the best prices and information now. That's ebpom.org.